This is a very exciting presentation because I think you've probably all heard through town halls and other activities about the excellent work that's being done by our Department of Medical Nutrition. So if I'm going to pull up my notes here to introduce our speakers. And today, they're going to talk about the impact of malnutrition on outcomes in hospitalized patients with COVID-19, such a timely and important topic. And our speakers today are Mariah Jackson, Dr. Jana Ponce, and Megan Timmerman. And all three are employees in our faculty in our medical nutrition department. In her current role, Mariah conducts clinical and epidemiologic research related to nutrition and cancer, as well as teaching in the program. And Dr. Ponce completed her MS and PhD at UNMC. She is experienced as a clinical dietitian, which is motivating her research agenda. And our last speaker is Megan Timmerman, who is the nutrition manager at Nebraska Medicine. And so she teaches on leadership and management in the program. So with that, I'll let you present a very exciting topic today. Thank you.
Okay, I'm happy to kind of kick things off. I don't know if Jana, if you just want to, if I say next, you can go on. As Laura said, we're presenting the impact of malnutrition in patients with hospitalized with COVID-19. So if you go on, yes. So I'm just going to start things off talking about a little bit background of what is malnutrition to kind of guide things as we go forward in this presentation. So a kind of broad definition of malnutrition is a state resulting from either a lack of intake or uptake of nutrition that leads to altered body composition, which we see clinically as decreased fat mass and muscle mass, which then leads to diminished physical and mental function and impaired clinical outcomes from disease. And malnutrition can result from starvation or different disease states, or even just advanced aging, alone or in combination of those things. You can go next, Jana. So why do we see malnutrition? As kind of stated in that definition, it's really stemming from a lack of intake to meet the needs of that patient at that point in time and what they're needing. So they may have some sort of disease state or condition that is increasing their energy and nutrient needs, and therefore the current level of intake that the patient is having is not meeting those. So such as having a fever or different kinds of trauma or chronic conditions. Or on the other side, it could be a problem with the absorption of those nutrients are impaired, whether that be from some enzyme defect and you can't break down the nutrients to absorb them, or maybe it's a problem with the amount of gut or intestinal length the patient has that we just don't have enough to absorb enough nutrients. Go next, Jana. And so what does this all come down to? How does this impact our outcomes in these patients? And so it's well documented that malnutrition has a profound impact on many important outcomes for both the patients and healthcare as a whole. And this is a graphic from the American Society for Parenteral and Enteral Nutrition, or ASPEN, as we'll talk about going forward, just kind of detailing out what is the giant impact here that malnutrition has on our patients. So we can see from this graphic, malnutrition increases the risk of death by 3.4 times higher in those with malnutrition than those without malnutrition. Length of stay is longer, discharge rates to long-term care facilities are higher, and need for home health services are higher. It's also very costly to the healthcare system with that $58 billion annual cost. And it also increases cost of care within the hospital system. So as we see that kind of 73% higher cost in those patients who are malnourished than those that are not malnourished. The next. So it's also important to make sure we know who are at risk of malnutrition, to be cognizant of our at-risk communities, including older adults. Malnutrition has been found to be more prevalent in African Americans and those populations of lower socioeconomic status. And so how do we identify those people who are at risk of malnutrition? The first step is really to do some sort of nutrition screening process of people who are at risk. And we know these patients who are at higher risk due to their morbidity, kind of things. So for patients who are admitted to the hospital, here at Nebraska Medicine, we use the malnutrition screening tool, or the MST. And so that ASPEN, or the American Society of Parental and Enteral Nutrition, as I talked about earlier, recommends using one of these standardized validated screening tools, such as the MST. And we conduct the MST within 24 hours of patient admission to see if they are at risk of inadequate intake or have had previous weight loss. And so it's important to remember that patients may show up to the hospital well nourished, and then over their course of stay may develop malnutrition. So monitoring ongoing of those at-risk patients is very important. The next. So then how do we diagnose malnutrition? There are 6 criteria established by ASPEN, and I've listed those here on the slide. And so malnutrition is diagnosed if 2 or more of these criteria are met. And how we diagnose malnutrition is really a systematic approach with reviewing the patient's medical record, talking with the patient or their caregiver about their history of eating and weight loss. And it also involves a physical assessment. Nutrition-focused physical exam, or NFPE, is really a key component of what a dietitian can bring to the care team. So with all of that put together, we have these 6 criteria that impact how we diagnose malnutrition. And each one of these has their own standardized definition of how much is insufficient energy intake, or how much is weight loss within what time frame. So these are just the general categories of what we're looking for. And 3 of those, the muscle mass loss, the fat loss, and the edema or fluid accumulation, we can do with that nutrition-focused physical exam as a dietitian, as a part of the care team. So that's just a really brief introduction into what malnutrition is, to give you a little bit more background into why we are looking at it in relation to COVID. So I'll hand it off to Jana.
All right, I'll take it over here. And here's where I'm going to introduce the study that we did using the N3C, which I'll talk a little bit more about later. A little bit more background and relevance to this research. We know that the COVID-19 pandemic has swept the globe in the past 2 years, with over 276 million cases and 5 million deaths worldwide. When it comes to malnutrition, the etiology is really often split up into 2 different processes, either in a chronic or an acute process, with the chronic process generally being related to something like chronic disease or starvation, while an acute process is generally something that's more associated with inflammation. We know that malnutrition is associated with weaker immune responses and decreased diaphragmatic and respiratory function. So we might assume someone that has a history of malnutrition may be more susceptible to a COVID-19 infection. On the other hand, those that don't have underlying malnutrition may become acutely malnourished during COVID-19 hospitalization due to side effects of COVID-19, such as anorexia, nausea, vomiting, and hypermetabolism. With those things in mind, our research team hypothesized that a history of malnutrition or becoming malnourished during hospitalization is associated with increased mortality and poor clinical outcomes in patients hospitalized with COVID-19. Although previous studies have explored the relationship of nutrition risk and malnutrition in patients hospitalized with COVID-19, we found 3 gaps in the current knowledge. First, limited US data are available assessing prevalence of malnutrition in patients hospitalized with COVID-19. Second, no US studies have assessed the impact of malnutrition on outcomes, including mortality in this population. And third, the differential effects of that pre-existing versus hospital-acquired malnutrition on outcomes in patients hospitalized with COVID-19 hasn't been investigated. So we'll move right on along to our methods. This retrospective cohort utilized longitudinal data from the National COVID Cohort Collaborative, or N3C for short. The N3C was developed by the NIH and systematically collects regularly updated data derived from electronic health records of patients that were tested for COVID-19 or had a diagnosis of COVID-19 from their medical provider. Data partners include contributing institutions encompassing multiple providers and multiple sites of care across the United States. And our final data extraction utilized data from release 55 and occurred on December 2nd, 2021. In this study, we included adults who had been hospitalized with COVID-19 and were hospitalized within 14 days of that diagnosis. Exclusion criteria included patients from sites with incomplete death or hospitalization reporting, patients with missing gender or age, along with pediatric patients under the age of 19, and finally, patients without a COVID-19 associated hospitalization within 14 days of COVID-19 diagnosis. This left us here at the bottom with our final hospitalized study cohort. Malnutrition served as the primary exposure in the study and was defined by the presence of one or more of the 16 selected ICD-10 diagnostic codes within the hospitalized patient's medical record. And all of these diagnostic codes can be seen in these colored boxes over here on the left-hand side of the screen. Those with malnutrition diagnosed prior to COVID-19 infection were classified as having a history of malnutrition, and those with malnutrition diagnosed on or after COVID-19 infection were classified as having hospital-acquired malnutrition. Patients included in the final hospitalized study cohort were then stratified into 3 malnutrition groups for analysis. The first group included patients with no documented history of malnutrition. The second includes those with a history of malnutrition. And the third and final group includes patients with hospital-acquired malnutrition. The primary outcome of this study was mortality, defined as the ICD-10 code of death or transfer to hospice during hospitalization. Secondary outcomes, also defined as presence of an ICD-10 code within the medical record, included the following adverse hospital events: mechanical ventilation, acute respiratory distress syndrome, or ARDS, extracorporeal membrane oxygenation, or ECMO, and hospital-acquired pressure injury, or HAPI. Frequencies and percentages of demographic and clinical characteristics between the no documented history of malnutrition, and hospital-acquired malnutrition groups were calculated. Groups were then compared using either the Wilcoxon rank sum test for continuous measures or the chi-square test for categorical variables. Finally, univariate and multivariable logistic regression models were used to evaluate odds ratios of mortality and adverse hospital events in patients within each malnutrition group. Adjusted models were controlled for age, sex, race and ethnicity, Charlson Comorbidity Index, and smoking status. These confounders were all determined a priori using directed acyclical graphing, knowledge of clinical relationships, and relevant literature. We considered a p-value of less than 0.05 statistically significant. Moving on to our results. The final hospitalized cohort included a total of 343,188 patients hospitalized with COVID-19 in the United States. Geographic distribution of the patients can be seen on the map on the left-hand side of the screen. 316,271 patients, or 92% of the cohort, had no documented history of malnutrition. 11,206 patients, or 3.3% of the cohort, had a history of malnutrition. And 15,711 patients, or 4.6% of the cohort, had hospital-acquired malnutrition. Overall, 7.9% of the final hospitalized cohort had a diagnosis of malnutrition. And the forest plot on this slide are the results of our univariate logistic regression. Outcomes of interest are seen here on the left-hand side of the column. Malnutrition status groups and odds ratios with 95% confidence intervals are here in the middle, and the p-values are to the right. As you can see here, odds of mortality in each adverse hospital event were significantly higher in patients with a history of or hospital-acquired malnutrition when compared to patients with COVID-19 who had no documented history of malnutrition. Following adjustment for age, race, sex, race and ethnicity, CCI, and smoking status, results remain statistically significant for each outcome of interest. Odds of death or transfer to hospice were 1.7 times higher in patients with a history of malnutrition and 2.5 times higher in those with hospital-acquired malnutrition. In the same respect, odds ratios of mechanical ventilation were approximately 1.8 times higher in those with a history of malnutrition and 5.7 times higher in those with hospital-acquired malnutrition. Having a history of malnutrition increased odds of acute respiratory distress syndrome by about 1.1 times, and hospital-acquired malnutrition increased those odds by 2.5 times. Odds of ECMO were approximately 5 times higher in those with a history of malnutrition and 13 times higher in those with hospital-acquired malnutrition. Finally, odds of hospital-acquired pressure injury were 3.6 times higher in those with a history of malnutrition and approximately 7 times higher in those with hospital-acquired malnutrition. On to our discussion and conclusion. To the best of our knowledge, this is the first nationally representative study to evaluate the following. First, the prevalence of malnutrition in adult hospitalized patients with COVID-19 in the US. Second, the impact of malnutrition on mortality in adverse hospital events in patients hospitalized with COVID-19. And third, the variances in outcomes between hospitalized COVID-19 patients with a history of malnutrition and those with hospital-acquired malnutrition. This research is limited by its use of retrospective data and reliance on ICD-10 codes, diagnostic codes, rather than the Academy of Nutrition and Dietetics and ASPEN guidelines, which is considered the standard of care for identifying and diagnosing malnutrition. And those were the guidelines that Mariah had presented earlier. However, at this point in time, the N3C database is the most representative sample of patients with COVID-19 in the United States. In conclusion, pre-existing and hospital-acquired malnutrition are associated with increased mortality and poor clinical outcomes in patients hospitalized with COVID-19 in the United States. This study highlights the importance of early and reoccurring nutrition assessment to ensure accurate malnutrition diagnosis by interdisciplinary teams. The identification of patients with malnutrition allows for a precision nutrition approach to care, allowing healthcare providers to implement individualized nutrition therapies designed at optimizing the metabolic response and improving clinical outcomes. With that, I'm going to turn it over to Megan to kind of discuss with you all how we've taken this and translated it to our practice here at Nebraska Medicine.
Thanks, Jana. So in both Jana and my positions, we are dual faculty at UNMC and Nebraska Medicine. And in this position, we are uniquely poised to be able to affect practice change based upon this research, as well as evidence-based practice guidelines. And that is what we did. First, we wanted to understand our internal nutrition challenges associated with COVID-19 patients. First, there's a known increase in hospital-acquired pressure injuries in patients with COVID-19. And how we came to this conclusion is through collaboration with the COVID nursing units. They noticed a documented increase in HOPI happening in these patient populations. A deep dive of the medical record indicated that poor nutrition was a component of the development of these HOPIs in these patients. Number two, a history of or hospital-acquired malnutrition significantly increases the odds of mortality and adverse hospital events. Things that are important to hospital administration are things like length of stay, increased mortality, as well as the increased incidence of HOPI in patients that are admitted. Patients who are admitted with COVID-19 are often at significant risk of malnutrition, and this may be caused by many days of poor oral intake prior to admission. Once they are here, they continue to eat poorly, and we know that significantly puts these patients at risk. So does their disease state, causing them to be very, very metabolic. We also looked at the accuracy of the MST collection on admission, and we identified a need for additional nursing education with a large number of traveler nurses that were being utilized within the hospital. Number three, we identified a need for more aggressive nutrition interventions to address this issue for these patients. We know that malnutrition can be prevented or attenuated with appropriate nutrition care. And we had seen an increase in hospital-acquired pressure injuries in-house. And we knew there was resistance from medical teams on more aggressive nutrition intervention. Oftentimes, we are approached with the attitude of wait one more day and this patient's intake will improve. And we knew that this barrier was essentially compounding the problem we were having at Nebraska Medicine. Okay, go ahead, next slide. So what our response to this issue was, obviously we looked at this research and knew we needed to do something. We knew that information was being compounded from the reports that we were having from nursing. And so together as a team, we developed these following solutions. So first, we created a COVID nutrition team of nutrition therapists that were providing direct patient care for COVID patients on both the wards and the ICUs. Next, we collaborated with nursing leadership and nursing education teams on both the floor and ICU level to collaborate on finding solutions that we felt would address many of the issues that we had identified. Third, we sought to increase staff education by increasing the awareness of what malnutrition was, the importance of why nursing was collecting malnutrition data on admission, as well as really examining how are we collecting data to understand how our patients are eating once they are admitted. And then third, we worked together to create aggressive nutrition intervention pathways that are patient-specific decision trees to derive nutrition plan of care. Next slide. So after we began to work together with these teams, we realized that we needed to continue to find nursing champions, and we found them on each of the floors. And together with those nursing champions, we were able to find ways to communicate malnutrition risk, the importance of oral intake in patients. So we together created door signs that we can hang on the door. So when the nurse is walking in, they see a bright red apple indicating that this patient is at risk. By identifying the patient at risk, the nurse is cued into the fact that they need to be examining oral intake at a higher level, encouraging oral intake, and working together with their care team to make sure that patient meals were being ordered. We also created education with the nursing educators on the importance of that malnutrition screening on admission, as well as, again, on monitoring oral intake. We also have been working with them on finding strategies to reduce the hospital-acquired pressure injury risk. And we created a specific decision tree just for wounds. Nutrition therapists have received significant hesitation from teams when making more nutrition aggressive interventions. But part of the solution to that is that we have been working more closely with nursing. And in those collaborative meetings with nursing, we are finding that we are making some headway with these more aggressive nutrition interventions. We're going to the floors each day for radar rounds. And we do feel like medical priorities are changing to help introduce nutrition earlier. We also are seeking to put feeding tubes into patients earlier, provide supplemental parenteral nutrition when that patient is unable to eat oral intake or we are unable to access adequate enteral ways of feeding patients. And so we are finding that we are able to feed patients earlier and reduce the risk of both malnutrition and HOPI. And last, we have been working on communication plans with COVID teams to create buy-in. So we have gone to the quality team it's a high-level quality team to introduce this concept to leaders. We have met with the critical care leadership team to introduce our care pathways. And we also have identified an infectious disease champion, Dr. Cockett, that we are working with to disseminate this information from the physician level. Our next steps are that we hope to continue to integrate nutrition into other leadership teams with nursing to affect meaningful nutrition outcomes for patients in other ways. So this has been just such a great foundation for us to be integrated into other teams. Okay, next slide. So thank you for tuning in today. Do you guys have any questions for us?
I do, but I'm always the first one to jump in. Who else has a question?
I don't have a question, Laura. I have a comment. So you jump in with questions.
Well, first of all, I think on behalf of everyone, thank you for a very interesting and enlightening presentation today. That was fascinating. I'm curious, you talked at the end about how to change clinical practice. That was really exciting. Do you have buy-in from Nebraska Medicine to monitor or analyze patient outcomes to see if earlier intervention with nutrition methods improves patient outcomes, like looking at new policy versus post-nutrition policy?
Yep. Jana and I have been working with a couple different collaborators to start to look at that data. And we will start looking at Nebraska Medicine specific outcomes. The hard part is just, we hit this bounce of this great information and our COVID numbers dropped pretty significantly. So hopefully we don't have another wave of patients, but if we do, I think we have a very nice line in the sand, knowing when we started with this project. So that is for sure our next step. Jana, do you have any better or clearer thoughts on how to put that?
No, I think nutrition is always a really hard thing to study, at baseline, and then studying it in the hospital can be a little bit more difficult due to so many different factors. So we're trying our best. We've looked at length of stay and mortality in particular in patients that are malnourished versus not malnourished, but we really need that kind of line in the sand time, like Megan said, to say, this is where our intervention was specifically introduced, have a small washout period, and then be able to see our post patients.
Yeah, it's complicated.
Yeah, I have another comment because being of my age, we used to say it took 17 years to take research and turn it into practice, but COVID has turned that on its head. And so I want to commend you for conducting research and then actually applying it and making it applicable to others who review your work. It's fantastic.
Thank you.
Yeah, just wow. Some of the parameters you looked at are so, I mean, that's really eye-opening thinking about hospital-acquired malnutrition. And, working in an area in geriatrics like my background is in, we see the malnutrition a lot, but not so much the rate of the hospital-acquired. And so I look at it, some of those parameters you were looking at were related to acute stability in the hospital setting. But some of them, as you mentioned, were, related to physical function or mobility or things like that, or predictors of that. And so, we know in the research literature that if somebody is bedridden or immobile for a few days, even to weeks, like with COVID, the strength and aerobic capacity and bone loss, all of those things change. But now the rate that you just uncovered there with the malnutrition on top of that, some of these individuals are really at a functional fork in the road, whether they will ever be independent again or not. And those are the things that, and we're seeing that. What you're showing here corroborates what we're seeing in reality with skilled nursing facilities being glutted. Now that somebody's medically stable, that doesn't mean they're functionally independent or stable. And so there isn't room in the skilled nursing facility anymore for the rehab. And many of these people are going to the home setting now for rehab, where it's even more of a challenge, and they may not stay there, right? They may wind up having to have a higher level of care. So I'm looking at it with my physical therapist hat on, but this is such great work and such a great baseline, I think, for many to work from in trying to change some of the clinical decisions that are made around this. So thank you.
Yeah, I agree completely. I think it's so unfortunate that a lot of times people will come into the hospital completely malnourished, and sometimes we may get to them a little bit faster, but I think this research really shows that even if you're coming into the hospital completely well nourished, that those outcomes, something's going on in your body that's making these outcomes even worse, it looks like. So your body could be having a huge metabolic response, a very acute inflammatory reaction, and there's something that's happening that's even worse. So, we're saying we're waiting on these people, which is in turn making things even worse. And I think that's some of the things that we're trying to let the medical staff know at Nebraska Medicine, that, waiting that one more day could really impact these outcomes this significantly.
Well, and also something as inexpensive as putting a feeding tube down and giving a patient a liquid nutrition is such a inexpensive way to potentially mitigate some of this rapid loss that these patients are having, and turn around the time they're able to get out the door. And it seems to us so simple, and yet it has been such a complex, and a lot of it had to do in the early days where people were so afraid to do anything medically to these patients. And a feeding tube was just not in the realm of what was, even considered optional. And now I think we're a lot smarter about that.
Yeah, it makes me think too that, some of the advocacy needs to be obviously in your setting, but across the continuum of care then too, because, if these individuals are discharged home and nurses and physical therapists, occupational therapists, others are trying to improve their mobility and function, and a medical nutritionist, at least a consult, isn't part of that team, then we're losing all the ground that you would have made, so I think sometimes they're not part of a home care team as a member, the consistent member, but I think we need to remind ourselves, we need to be calling people in for some of these situations. Otherwise, the patients will be too far in a hole to make functional change,
Yes, that's true.
I also want to point out from an older practitioner's perspective that there's been several disease processes where there's a huge medical advance first, and then we as allied health professionals see, wait a minute, you're doing this, but you're missing out on all these opportunities, like post-hip fracture or cancer survivorship now, where lifestyle is at the forefront. But those changes don't occur without members of our community and team members raising their hand and being willing to share this information. So it's also such a great representative of the team members that you are at Nebraska Medicine. Any other questions? I'm seeing comments congratulating you on your work, and Dawn commented on something I think was really interesting too, that love the use of the large national data set. I have a very weird question, the nerd in me. How come the Midwest had the greatest number of COVID patients in your database compared to like the East Coast and the West? It's like 130 compared to one of the other groups had 26,000.
You know, I'm not positive. And especially, I don't know how many sites are located within the US that are reporting to the N3C versus other sites also. So that could be potentially some of it. So we had someone that was very smart at using this kind of data set to help us with all of the extraction and which sites we could use and which facilities we could use, and has like a very specific algorithm to why we used those. So he could probably speak better to that than I could. But so Nebraska Medicine is one of those reporting sites, which is really cool that we can say to our staff, these are results we see, and our affiliated hospital contributed to those results.
Yeah, that's very interesting. Thank you. If we don't have any more comments, then I think the group can join me in our Zoom applause, thanking you for a great presentation and educating us today. So it's been fantastic.
Thanks for joining us, you guys.